Right, so my last presentation is rather a lot of detail about tumors with EWSR1 gene rearrangements, but I want to cover a lot of entities that we haven't managed to fit in elsewhere, and also to give you an idea of some growing points in soft tissue pathology. Now, you've seen this before, and I want to make the point again that same genes can be found in different different animals can be found in tumors of the same lineage, and the same gene can be found in completely different tumor types, and that applies to single genes. And you've heard from Ken a very clear exposition of tumors with MDM2 amplification, completely different types. And there are several fusions, and I've mentioned before, that occur in lots of different tumor types. But one of the commonest, most frequently seen gene in fusions and rearrangements is the EWSR1 gene. And I've said an ever-expanding spectrum, and even as this week, we've had a couple of new entities published that have incorporated. And there are many, many such, and you can see from this table, not only are there many tumors with EWS, but there are many tumors of the same type where there are different EWS partners within that tumor type, such as myoepithelial. I can't obviously cover all of these, and by the way, you notice some of these are not mesenchymal. If we take those out, we have these tumors which are soft tissue or mesenchymal. I'm not going to talk about bone tumors particularly. So I'm going to focus on three areas: the Ewing-like tumors, the EWS-CREB family rearranged tumors, and myoepithelial tumors. Let's start. Ewing sarcoma, of course, is very well known from many, many years ago from Ewing, James Ewing. And this was initially described as different clinicopathologic entities: Askin tumor, bony Ewing, soft tissue Ewing, all thought to be different, with some histological subtypes, now known to be the same tumor with the same genetics or range of genetics. And this is the archetypal small round cell tumor with very uniform cells, which can have glycogen, not unique to Ewing. We still sometimes use it. Can have rosettes, and it can be an atypical Ewing with larger cells nuclei, many of which are actually found to be other tumor types, now including sick duct or Vico. Hallmark is CD99 strong diffuse membranous positivity, with some having dot keratin, and that picture is good for Ewing. A subset also have ERG positivity, which I've already mentioned, and of course these are the EWSR1 ERG fusion tumors. The immunohistochemistry now is wider, and of course you tend to use a wider panel for small round cell tumors, and I've mentioned some of these already, but newer markers that are being advocated and may be useful include NKX2.2 and PAX7. PAX7 is very good for Ewing sarcoma. The problem is it's not specific. So again, if it's negative, it's only 10% chance of not being Ewing, but also found in the NFAT-C2 and the PAX-Z1 and some other tumor types as well. But desmoplastic small round cell negative, and a few other types down here negative. So as part of a panel, it may have its value. If we look at the next group of EWSR1, we'll come back to that. That's one we're going to come back to. NKX2.2 has also been advocated as a marker, but suffers from the same problem. It's positive in Ewing sarcoma, but also the NFAT-C2 tumors. Olfactory neuroblastoma isn't likely to be in the differential usually, but mesenchymal chondrosarcoma often is, and that's also CD99 positive. So you may need genetics to distinguish these, but also desmoplastic small round cell tumor negative, which can be helpful. Now, Ewing sarcoma had not just these typical these typical ETS fusions, the FLY1 and the ERG, which account for 95% of Ewings, which is why doing FISH for EWSR1 is very useful, although I also do the FUS at the same time because some of them have a FUS. But there are also a lot of non-ETS group of genes which form fusions and which account for a small proportion of Ewing-like tumors. I've listed some of them here. Many of them are only single or very small series, but there are two types that have emerged, the MFAT-C2 and the PAX-Z1, that I'm going to talk about as distinct entities. The tumors with EWSR1 or FUS, and it can be either, with NFAT-C2 fusion occur in young adults and mainly in bones. Yes, I'm not talking about bone tumors, but this tumor occurs predominantly in bones. It's a less aggressive neoplasm than Ewing with a 10-year survival of 56%, so gradually keeps going after 5 years, 75%, and less chemoresponsive. The patterns here you can see very nicely are sort of myoepithelial-like, with cords of cells with some discohesion in a fibrous stroma. There can be focal pleomorphism and there can be focal osteoid or chondroid change. The immunohistochemistry of these is very wide and has CD99, again, cytokeratins, PAX7. It has NKX2.2, and also NKX3.1, which can be a useful marker because it seems to be fairly specific for this tumor, as well as for mesenchymal chondrosarcoma. And agrican has been postulated to be useful in this diagnostic situation. Now, very recently, the same fusions, FUS-NFAT-C2 or EWSR1-NFAT-C2, have been described in simple bone cysts, again from 2 centers. And not only that, this has been expanded by finding them in vascular malformations, again in bone. So this is a very unusual example of the same fusion being found in both benign and malignant neoplasms. You shouldn't, of course, have a problem distinguishing them because they all look completely different. But I think it's a very useful conceptual situation. Now, I mentioned NKX 3.1, 3-1, and this can be very useful if you have it for picking out EWSR and NFAT-C2 tumors. Interestingly, not the ones with the FUS gene in the fusion. So as I mentioned, it just picks out the NFAT-C2 EWS and the mesenchymal chondros. All the rest are negative. Potentially then, this is a very useful marker in this situation. But if you've been following the literature, you will know that it's a little bit antibody and technique dependent. One group found it to be negative in NFAT and another found it to be positive. I won't name the groups. Now, the other subtype that's emerged with EWSR1 fusion is in the kind of small round cell territory is EWSR1 PAT-Z1, PAT-Z1 if you're English, and this occurs in soft tissue, more commonly in females, intra-abdominally or abdominal wall and thorax. It varies in behavior, and there are sheets and nests of small round cells and of spindle cells which are in fibrous stroma. This has a very unusual immunophenotype with CD99, PAX7, okay, but also desmin and myogenin MyoD1, and S100 protein, and GFAP, and sometimes keratin. It's a polyphenotypic neoplasm. If you spot the desmin and myogenin, you might be concerned this is rhabdomyosarcoma. By the way, also hot off the press, this EWSR1 PAT-Z1 fusion has now been described in thyroid-like follicular renal cell carcinoma, completely unrelated. And this, by the way, is desmin myogenin negative. But if you were misled into thinking it's rhabdomyosarcoma, beware of spindle cell sclerosing rhabdomyosarcoma. I just wanted to slip this into this presentation as a differential diagnosis. And these fall into the infantile group with NCOA2 mostly fusions, a subgroup with a MyoD1 mutant, and an intraosseous group, which looks like this. And these can be sclerosing or spindle cell. These are the 3 groups now classified into in the WHO, the new WHO classification. But beware, if you just think it's a rhabdo and it's an EWSR PAT-Z, you can actually almost resolve it with fish, except for this, where there's an overlap. Ewing sarcoma-like tumors with non-EWSR1 fusions are increasing in number. I've listed them here. I'm not going to talk about them. Kim will talk about them later, just so you're aware that not all small round cell tumors have EWSR1. Now, that was a large group of Ewing-like tumors I wanted to start with. I'm now going to go on to another group, which is emerging with increasing numbers of members in this WhatsApp group. EWSR1, ATF1, EWSR1, CREB1, EWSR1, CREB. These three partner genes are all related. They're all part of the same Krebs group, and they are found in several different tumor types in soft tissue and in non-soft tissue. Let's start with the archetypal tumor angiomatoid fibrocystic which was initially called angiomatoid malignant fibrocystic in the heyday of MFH, 1979. And this was an aggressive neoplasm in the first report, of black and white. That's what there was in those days in publications. And it showed a circumscribed tumor with a capsule and with lymphoid aggregates, you can almost see on low power, and central cystic hemorrhage. And when we see it in color, you'll see how very nice this description was of the aggressive neoplasms at that time. Subsequently, two large series from the same place, the AFIP at that time, showed a much better outcome. The first series of 108 cases showed only a 5% metastatic rate, and the tumor became reclassified as intermediate, and the malignant was dropped. The third series from the AFIP, 9 years later, actually showed only a 1% metastatic rate. So either the diagnostic criteria have changed, or people are treating them earlier, or whatever. Anyway, it's getting better. It's no longer malignant, it's just AFH. This is what it looks like. It starts as a solid subcutaneous lump. It acquires central cystic hemorrhagic spaces. Note the lymphoid periphery. The cystic spaces can enlarge. You can end up with a rim of tumor with its fibrous capsule that can be very thick with hemosiderin, and this one has lost its lymphoid aggregates. The cells look quite fibrohistiocytic with a bit of spindling, and you can imagine that looks like a bit like a fibrocystic skin, can be more spindled, and there is often hemosiderin deposition and sulfony macrophages. The lymphoid cuff can make you think this is a metastatic tumor in lymph node. This is a metastatic AFH in lymph node from a primary in the scalp, and you can see it's got lymph node architecture and a sinus and all the rest of it. So it's quite different. So be careful to look for lymph node features before you diagnose this as a metastasis in a lymph node, unless, of course, it is. But that patient already had a primary known tumor nearby in the scalp. Unusual features include spindling, rhabdoid change, and so on. Here's just an illustration of some of these. There's a spindle cell variant, which is quite hard to diagnose without genetics, myxoid variant, more myxoid variant, and more myxoid variant. The immunohistochemical hallmark, although not in every case, is desmin, and this can be focal or diffuse and quite strong, as here. And this, however, only in about 50%. I think it's probably slightly more now. These are older figures. And other muscle markers, not so much. SMA maybe, calponin's good, caldesmon usually not. You can have CD99 and EMA. But more recently, ALK has emerged as a marker for this tumor type. Once again, this is clone dependent, with our old friend ALK1 being rather weedy at this and not very good, whereas D5F3 is quite good and picks up most of them. This is not, by the way, associated with an ALK rearrangement. It's some sort of amplification. Genetically, this tumor first was discovered to have a FUS-ATF1, then EWSR1-ATF1, and now the most common 90% of cases have EWSR1 CREB1, and a smaller number have got this emerging partner of CREM, with EWSR1 CREM, mostly in myxoid tumors in middle-aged males. So because of this, EWSR1 FISH is very useful for diagnosis. The important differential not to confuse it with, and terminologically similar, is aneurysmal fibrocystiocytoma, which is a dermal tumor. It's simply a variant of cutaneous fibrocystiocytoma with hemorrhage, cystic spaces, lots of giant cells, siderophages, and so on, and of course doesn't have desmin and doesn't have the genetic changes, and is not circumscribed with a lymphoid cuff. And by the way, the AFH is not dermal. The angiomatoid FH, it's subcutaneous. The next entity is, don't worry, I'm not going to do all of these. I just want you to have the list and show you where I'm at. Clear cell sarcoma of soft tissue, also described from the AFIP by the great Dr. Enzinger in 1965. based entirely on morphology, by the way, but they've stood the test of time as entities and been shown to be genetically distinct. And this was another high-grade tumor with very poor survival, most of them dead of disease, but certainly within 10 years. An extremity tumor involving or arising from tendons and aponeuroses. Here are two examples. This is arising from this flexor tendon of the finger there, and this is from the Achilles tendon at the back of the heel, ulcerating through the skin. This forms islands of cells within fibrous stroma, large islands, and the cells can be seen to be fairly clear cytoplasm and uniform nuclei. By the way, this is one of the few uses of reticulin stain to show the nested pattern. There's a cytology showing you these uniform punctate basophilic nuclei, distinct nuclear membranes, and clear amphiphilic cytoplasm. There it is again, showing you the nuclei. Sometimes there are multinucleated giant cells, which are actually tumor cells for the most part, and this is a useful feature. Note there's no pleomorphism because it's a translocation-associated neoplasm. Variants, eosinophilic, spindles, myxoid, and sclerosing, all have to be recognized and can be difficult to spot, but fortunately quite rare. Immunochemistry, very useful. S100 protein, HMB45, and melan A. It's a melanocytic, melanogenic neoplasm. HMB45, more sensitive than melan A. Can have occasionally neuroendocrine markers and sometimes EMA, even cytokeratin. So, but you probably wouldn't do them. If you suspected it, you just do the melanocytic markers and the antigens, SOX10 as well. And you might come up with melanoma, but you need to be able to distinguish that, which we'll do in a moment. And the genetics of this, they're mostly EWSR1-ATF1, and some are CREB1, and now emerging very rarely, but will no doubt be more, is EWSR1-CREM. On gene expression profiling, this clusters with melanoma and expresses melanogenic genes. And there are a couple of other tumor types it needs to be distinguished from with different genetics, one with CREM and the CRTC1 TRIM11. Unlike melanoma, BRAF mutation is very uncommon, so you can do that at the same time as to give some therapeutic guidance also, because it's no use in this particular tumor. Differential diagnosis, metastatic melanoma. Well, look, you haven't got the pleomorphism of melanoma. You've got no overlying junctional activity or primary elsewhere. You have got very strong, usually melanocytic markers, more than in melanoma. And otherwise, it could be. So if you don't have access to genetics, make sure there is no primary elsewhere, and this is not connected to skin. But the uniformity and the general appearance should give you the clue and get the fish done, and that will give you the answer. And then a couple of other tumor types, cutaneous melanocytoma with CRTC1 TRIM11, and then the MITF-CREM that I mentioned. I'm not going to go into, but they have to be distinguished or borne in mind, and they're really for dermatopathologists. But I will mention PIComa, because it doesn't fit anywhere else today, and it's an important emerging tumor. This has often a clear cell morphology like clear cell sarcoma. It is associated with thin wall sinusoidal vessels to which the tumor cells cluster. In the skin, it can be very clear cells, and here's the pleomorphic malignant variant. The histochemistry, again, is HMB45, melan A, and microphthalmic transcription factor, melanocytic antigens, but usually not so much S100 protein. But there is also SMA, and sometimes desmin and caldesmon, so myomelanocytic immunophenotype. Focal S100 should not deter you. TFE3 is positive in the nuclei in a subset of these. We'll see why in a second. Cathepsin K, if you happen to have it, is actually a useful marker. We do not, but I'm sure it would be helpful if required. The genetics, of course, is quite different from clear cell sarcoma. One subset is TFE3 arranged, and this is the ones with the TFE3 immuno. Another subset have tuberous sclerosis gene 2 mutations, and that's 80% of them, the TFE3 fusion negative and not the TFE3 fusion rearranged. And again, there's a gynae or pelvic subset that have their own fusions as well. The point being, this can easily be differentiated from clear cell sarcoma, probably by FISH3WS as well as EWSR1 as well as immunohistochemistry. I'm sorry, EWSR1 used to be called EWS when I was young, and I slip. Gene names are constantly changed by those who know better. So next tumour in is very similar to this, a clear cell sarcoma-like tumour of GI tract, which has also been called malignant gastrointestinal neuroectodermal tumour. I'm not happy with that term because it's not very specific, because neuroectodermal markers are seen in other types of tumour, including clear cell sarcoma. Anyway, this is an aggressive neoplasm. The M bit is correct. Predominantly small bowel and also stomach, often with metastases at presentation. Here it is in the bowel wall, mostly submucosal, but can also infiltrate the mucosa as a multinodular tumour with a fibrous stroma. It has a variety of morphologic manifestations. It can have nested clear cell pattern like the usual clear cell sarcoma soft tissue, with giant cells even. It can have a discohesive nested-like pattern, and it can have a short spindle cell, random, solgy-fibrous tumor-like pattern, or even resemble plasmacytoid tumors or rhabdoid tumors, or even lymphoma. It's a very protean tumor in its manifestations. Immunohistochemically, this differs from the clear cell sarcoma soft tissue on the right in having S100 protein and SOX10, but no melanocytic markers. It can have neuroendocrine markers, hence the terminology, but both of them can. So if you think it might be this, S100 and SOX10, again, you have to exclude a melanoma elsewhere, and there's no doubt that some of these were thought to be metastatic melanomas originally. Do the markers, and if it's negative for the melanocytic markers, go ahead and do the FISH, which usually shows EWSR1 CREB1 and a smaller number having EWSR1 ATF1. It's not yet clear whether CREM takes part, but there's no doubt that it will in due course. Now, my favorite tumor of the day, primary pulmonary myxoid sarcoma. This is because we wrote up the first series, or rather Dr. Thway did. And we found, I think, 10 cases with EWS CREB1 in the lung, confined to the lung. And this is in young adults, mostly females, can be parenchymal or endobronchial, low-grade tumors, of which 2 metastasize to kidney and brain. It's an unusual tumor in that it has a variety of patterns, but none of which quite matches anything else. So here's the endobronchial with the cartilage, a multinodular myxoid tumor with reticulated pattern of cords of often splan-looking fibroblast-like cells, very complex reticulated pattern, and sometimes cords of cells resembling myxoid chondrosarcoma, which you've heard about earlier from Kim. So the more typical pattern is this, where you see these reticulated branching cords of fibroblast-like cells. The immunohistochemistry is disappointing because it's negative for all the markers found in the other tumors in this group. Some of them have a bit of epithelial membrane antigen. And nearly all of these have only CREB1 in the fusion. And this is usually, it's the same fusion actually as in clear cell sarcoma. Since we published our series of 10, there have only been something like 27 cases. So it's rare, mostly endobronchial. They've all had CREB1 except this one case that probably isn't this. And where there's been FISH, only EWSR1. And interestingly, 4 out of 24 metastasized, which is exactly the same ratio as we found in our original series. It has been suggested these are simply angiomatoid fibrocystocytomas of lung. There are some differences. The morphology differs with cords and sheets of cells. ATF1 in AFH has only been described in one tumor, in one example of AFH. Of PPMS. And also, myxoid change is rare in AFH, and desmin is not found in the PPMS. So far, I think they're different tumor types, and also this tends not to metastasize. So far, I think they're different tumor types, but maybe they'll coalesce on the grounds of common molecular, because that's the way things are going. Well, that was all well and good, and then the pathologist and the neuropathologist got together and found tumors inside the head, which had the same transcriptions, the same fusions, and transcription factors in the fusion, and they defined a novel myxoid mesenchymal tumor with a predilection for intracranial location. And you can see this is distinctive Its patterns are not quite like the other tumor types. There are some branching cords as myxoid change, amianthoid collagen fibers, and these had EWSR1 CREB or ATF1, and some of them had CREM in the partner gene. And in this initial series, CREM was also found in a couple of other non-cranial tumors. Some of these had EMA and some had desmin, so an inconsistent immunophenotype. Subsequently, a larger series was published with a unifying diagnosis for this spectrum. People are trying to push them together now with AFH, intracranial myxoid, mesenchymal tumors, and all the others as the same. I think they're not yet the same. They are different clinico-pathological entities with different behaviors, and we need to be able to still regard them and diagnose them separately. So there's a summary of the features of these intracranial tumors. But a further point of interest in this series, has the usual features, is that they were able to correlate, these authors, the pattern with the fusion gene, which is quite uncommon in this group of tumors. So the tumors with stellate or spindle cell morphology and myxoid stroma had the CREB1, and the ones with ATF1 had epithelioid or rhabdoid morphology and were more aggressive. The only ones that died had the ATF1. Therefore, it may be pertinent and clinically relevant to know what the partner gene is in these cases and to do the PCR or the NGS. This is once again a case kindly given by my prolific colleague, Dr. Sway. And this is an EWSR1 ATF1 intracranial mesenchymal tumor showing clear cell morphology, which has not been hitherto emphasized. So this is an expanding and emerging spectrum of tumor types in all parts of the body. The CREM partner is also emerging and displacing ATF1 and CREB1 because it's now found in some intracranial tumors, in myxoid AFH, clear cell sarcomas, and in some non-mesenchymal tumors of salivary gland, clear cell sarcoma-like tumor GI tract, hyalinizing clear cell carcinoma of salivary gland, and some others as well, and this will no doubt expand and increase. Now, a recent entity, which may or may not be a soft tissue tumor, has expanded this family of tumors, and this is a malignant epithelioid neoplasm with a predilection for mesothelial-lined cavities, mainly the abdomen. And once again, it's been described from 3 different places with different names. But these are all tumors with EWSR1 or FUS-CREB or CREM fusions, which have a very distinctive epithelioid morphology. Some of them are AFH-like, some of them have sheets of plasmacytoid or rhabdoid cells, and some of them have clear cells, and this is a case of ours from Dr. Sway again, which is an adrenal gland tumor. And this is a range of morphology which has some overlap with other EWS-CREB, but the difference is in the immunohistochemistry, because these are strongly keratin positive. They have EMA, they have WT1, but not calretinin. They can have ALK and also MUC4 focally. So they're more like mesotheliomas, but they have the fusions of many soft tissue tumor types. And in fact, the majority of them, putting all the series together, have a CREM in the fusion, half with EWSR1 and half with FUS. So this CREM is really going out there now and forming lots of tumor types, and I'm sure we'll see more of this. Now finally, I just want to move on to myoepithelial tumors. Now this is another expanding concept that is not absolutely clear to me what a myoepithelial tumor is, but they are described, and many of them are a little bit like the counterpart of the salivary gland type, as myoepitheliomas, mixed tumors if there's tubule formation or gland formation. About a third are malignant, and there's a subtype called cutaneous syncytial. The patterns are variable. There can be sheets of cells, branching cords, and a chondromyxoid stroma. And there are malignant variants, including carcinoma-like or sarcoma-like, and this is metastatic myoepithelial tumor in a lymph node. The immunohistochemistry is very variable, and herein lies the problem, because they are said to have epithelial and myoid markers, keratin EMA, S100 and SOX10, which are myoepithelial markers, and GFAP, another myoepithelial marker, and smooth muscle actin and calpolin and a bit of desmin, and half of them are iron I1, show iron I1 loss. The problem is very few of them have the complete immunophenotype. The minimum has been taken as EMA plus S100 protein as to be a definition for myoepithelial tumor with the appropriate morphology. I am not sure how convincing that is, and I would prefer, oh, I'm sorry, I said only one EM, it's the second one. I would prefer to do electron microscopy, which shows very nicely the epithelial toner filaments, the myofilaments, and the junctions, defining a myoepithelial tumor. But nobody does it anymore, and nobody can do it anymore. So I think that it's just not going to happen. But we have to accept now the minimum definition of EMA and S100. In fact, some practitioners are accepting myoepithelial tumors without any markers as well. Can we define them genetically? Well, here you are. This is an expanding list. The majority of them have EWSR1 or some have FUS, and that's useful to know. And there is some correlation of the fusion partner with the patterns, although not sort of absolute. And of course, many of these are very small numbers of cases, quite a few are malignant. Kin mentioned the PHF1 TFE3. That could be called ossifying fibromyxoid tumor with a very similar phenotype. And we run up against the old problem of how do we define these tumors now? Is it genetic or is it by other means? You've heard about EMC, a quick comparison because it's a differential diagnosis of myoepithelial tumor, one of them, and you've heard about the immunohistochemistry. Some of these have iron I1 loss, particularly the rhabdoid tumors. Insulinoma protein has been suggested as a useful marker. I have no experience of this, but already it comes up in some other tumor types, as you can see here, including myoepithelial tumor. And you've heard about the genetics. They all have NR4A3 with a variety of tumors. If you want to distinguish this from myoepithelial tumor, don't do the EWS and FUS fish. Do the NR4A3 fish, which, by the way, has changed its name several times. Just for the hell of it. Finally, you hope, the EWSR1 SMAD3 rearranged fibroblastic tumor is a new EWSR1 tumor on the block, and this is an acral tumor which occurs in any age group as a subcutaneous nodule. And this is a fusion of EWSR1 exon 7 with SMAD3 exon 5. What were these before? They looked like smooth muscle or myofibroblastic tumors, and possibly myopericytoma. That's probably where they were. And indeed, they can have central hyalinization or calcification, stippled, just like an infantile myofibroma. The difference, however, is this ERG positivity throughout, with a complete absence of muscle markers and other markers. So this is the EWSR1 SMAD3 rearranged tumor. And I put it in, A, because it's new and an ERG tumor, and also because if you have a myofibroma with negative markers, think of this. Does it matter? Well, it's benign. Now, finally, synovial sarcoma. We discovered this translocation now 34 years ago by the old-fashioned methods. And then we showed that the SSX1, SSX2 fused with the SYT, as it was then called. This was a very long-lasting and happy marriage. These two genes did not combine with anything else. They were faithful. But, eventually they got fed up and they started to branch out. And SSX1 is fusing with other gene types now, SS18L1, SS18NEDD4, and I've mentioned this already, but the problem now is we've got EWSR1 fusing with SSX1. And once again, 2 or 3 almost simultaneous studies, 2 with SSX1 fusions and 1 with SSX2 fusion. The SSX1 fusion tumors are sclerosing. They look like poorly differentiated synovial sarcoma. They do indeed have synovial sarcoma immunophenotype with epithelial markers T81, CD99, and some NOT4. But they have this EWSR1 SSX1 fusion. Do we call them Ewing-like tumors or do we call them synovial sarcomas? Here's a second large series, a few cases, three, with EWSR1 with SSX1. This time, they look more like synovial sarcoma and indeed include a biphasic examples, different parts of the body, thigh, mediastinum, and heart. So it may be that we're happy to call these synovial based on the SSX1, but there's a problem of diagnosis. Which fish do you do? Because we haven't got an SSX1 fish. Again, these have EMA, cytokeratin, TLE1, and CD99, and no MUC4. So it's the emerging concept of EWSR1 with SSX1. And there it is again. Incidentally, did I put it in? Yes. This series has exon 7 and exon 5, and this series has exon 10 and exon 4 or 5. So there's variation in these fusions, considerable variation. We would have called this synovial sarcoma in the old days, just based on morphology. And then finally, there's one tumor with EWSR1 SSX2 described in the bone. And this also looks like synovial sarcoma. And it has, again, the correct or usual immunophenotype with a few little frills, like lacking AE1, AE3, and EMA. So nothing's perfect. The fusions take place. They look like what they're supposed to be, more or less. They may not have the correct immunophenotype. What do you advise the clinician? You tell him it's probably a variant of synovial sarcoma at the moment, but we don't really know. By the way, this brand new antibody, SS18 SSX fusion antibody that's so good, obviously doesn't work for these variants. Right, finally then, EWSR1, remember, is found in non-mesenchymal neoplasms. Here is a list of those which is expanding, particularly renal cell carcinomas, salivary gland tumors. And I put this tumor, which we talked about here, because I'm not sure whether it's a soft tissue tumor or a non-mesenchymal tumor, because it looks like mesothelioma, but isn't. What can we conclude from this cornucopia of facts? Well, EWSR1 is apromiscuous, maybe the most promiscuous gene. Fish alone is not sufficient because so many tumors have it. You have to put it all in the concept, in the context. Demonstration of the fusion is usually necessary, but it's not always sufficient because fusions aren't specific either. New entities keep emerging. Do we change how we look at it? Do we stop talking about lineage and the terminology by morphology? And do we start naming them by genetics? It's coming in, but some of it's just a bit too clumsy. Imagine trying to tell a surgeon this. And the original names are very good. Clear cell sarcoma, synovial sarcoma, both completely wrong in a sense, but at the same time, descriptively accurate. Synovial sarcoma, nothing to do with synovium. But they persist. We all know what we're talking about. And more importantly, so do the surgeons and the clinicians of MDT. Thank you very much.